So hello friends, in this session, the previous session was about gram-positive bacilli spore-bearing organism. So now here it is in gram-positive bacilli which are the non-spore bearers. Okay, so first in this we'll be dealing with Mycobacterium tuberculosis. Okay, okay. The first slide it will be like a comparison between the tuberculosis and the leprae. Okay, so here the virulence factor for tuberculosis is mycolic acid, cod factor, lipoarabinomannan and heat shock protein. Okay, so here the primary important virulence factor is mycolic acid, whereas here it is in phenolic glycolipid. So coming for the generation time, here it is in 12 to 13 hours, here it is in 12 to 13 days. So here culture medium is Lowenstein-Jensen medium. You know it is in rough, tough and the buff colored colonies. And here usually there is no growth in the artificial medium, but it can be grown in the food pad of the mice. Okay. So coming for sulfuric acid, here it is at 20% and here it is at 5%. So these are the general characteristics of the species. So now these are the, you just compare it. Okay. So virulence factor, generation time, culture medium, sulfuric acid. So next we will be dealing with clinical manifestations of the pulmonary tuberculosis. So here, so the most common site involved in primary tuberculosis is subpleural lesion, that is usually present, that is an upper part of the lower lobe and the lower part of the upper lobe. Okay, so whereas in the post-primary tuberculosis, it usually affects the apical and the posterior segment of the upper lobe, because here there is an availability of an high oxygen levels. Okay, so next it is an so friends, I have been posted some of the focus. You know that is an Asman focus, Simon focus, and I will be posting a link in the description box. Kindly go through that. So now these are the pulmonary tuberculosis. So what about extrapulmonary tuberculosis is? So here, just remember, see. So primary, it will be affecting your lungs. So coming for the most common extrapulmonary site tuberculosis is lymph node. Okay. So among the lymph node, the important is posterior cervical and the supraclavicular lymph nodes. So coming for genital tuberculosis, it usually affects the fallopian tube and the endometrium. In males, it usually affects an epididymis. So coming for skeletal tuberculosis, it is in pot spine. Okay, that is it usually affecting and weight bearing joints, and the tuberculosis spondylitis, it is also most common. But just remember the pot spine, and what are the other common affected is hips and the knees are also affected. So coming for GI, it usually affects the terminal ileum and the cecum. You can remember like ileocecum. So what is another most common in ileocecum? It is an amoebic ulcer. Okay, so amoebic intestinal ulcer that also affects an ileocecal area. Okay, so friends, these are the clinical feature of the tuberculosis. So now we will enter into the leprosy clinical feature. There's a classification called as a Ridley-Jobley classification. So tuberculoid, borderline tuberculoid, borderline lepromatous, and lepromatous leprosy. Okay, so here so this is an important phase. Okay, so if the patient is in borderline, he can develop a better immunity and he can shift over to tuberculoid, or it can get worsen and he can enter into a lepromatous. Okay, so this is a time deciding factor. So coming for clinical manifestations of tuberculoid, we just remember paucibacillary means the skin lesions will be about 1 to 5 skin lesions only, and one nerve will be usually affected. And here the most common nerve involved is ulnar nerve. Second, it is in posterior auricular nerve, and lepromatous will be posittor. So whereas in lepromatous, fit opposite, that is an multibacillary means it will be having more than 6 lesions, and so nerves always more than one nerve will be involved, and the patient will be having a typical leonine faces, that is there will be absence of eyebrows and the saddleness, nose deformity will be there, and corneal opacities will be there. Here the lepromatous test is negative. Okay, so I think you can follow, right? So first we dealt with our general characters. Next we finished about the clinical features. So next we will enter into the lab diagnosis. That also will be in the comparison because these two will be somewhat similar. Okay. So here first, what about specimen? In pulmonary tuberculosis, we'll be taking a two sample, one in the spot, another one it is in early morning. Okay. So whereas in lepre, you will be taking a total 6 samples, 4 from the skin, that is in forehead, cheeks, chin, and the gluteal region. And you can also take any earlobe or the nasal mucosa. Okay. So here staining. So percentage we already we discussed, right? What is the percentage for the tuberculosis? It is in 20, and for lepre you will be using in 5. So here acid fast staining, it will be usually positive only if there is a bacilli count of about 10,000 bacilli per ml of sputum. So here what we will be seeing, you will be seeing a slender pink stain acid fast bacilli. Whereas here in lepre, you won't remember, there is a special appearance called as a cigar bundle appearance, and there is another cells also called as virchow cells or lepra cells. They are the foamy macrophages which have been laden with the bacillus. So coming for BACTEC or MGIT, that is a mycobacterial growth indicator tube. What happens here is the tube is already, it will be like quenched with the fluorescent compound, and it will be having oxygen. So the bacteria, what will happen if the bacteria is present, that is in Mycobacterium tuberculosis, it will consume all the oxygen and it will emit the fluorescent compound. Okay, so here so in MGIT you can also find out the resistance of the first line of the drugs. Whereas here in lepre, an antibody is usually detected by FLA absorption test or by the ELISA. Okay. So next important, that is here we will be using a tuberculin test, here we will be using a lepra test. So tuberculin test, what you will be doing here is 0.1 ml of purified protein derivative. You will be taking and will be injecting intradermal into the flexor aspect of the forearm. Okay, so you'll be reading the findings after 72 hours. What happens here is if it is more than 10 mm, it is in positive. 6 to 9, it is in doubtful, and less than 5, it is in negative. So whereas here lepramin test, same. See, you'll be taking a 0.1 ml of lepramin antigen and you'll be putting in an intradermal injection, and again 48 and 21, but here it is in about 48 to 72. No, so what happens here is the 48, it is an early Fernandez reaction, and 21 days it is in late Mitsuda reaction. So here what happens is if there is an induration or erythema of more than 10 millimeter, means the patient have been exposed to the lepra bacilli. Okay, and it does not indicate the patient is at an active replication. Whereas in late, it is a nodules of more than 5 millimeter, it is considered as a positive. What happens is later it become indurated and it become an ulcer. It indicates that, oh, the patient's CMI is usually intact. Okay. These are the two important tests you want to remember. So next it is in, what is that? Okay. So in tuberculin test, the adult usually positive means it indicates they have been infected with tubercle bacillus, whether usually it can be in past or it can be in present, but it does not confirm the disease, but we can't make, oh, the patient has been affected at present. So you can just you can make an idea, okay, he has been infected with Mycobacterium tuberculosis, and it is used as an epidemiological marker. Okay, so here the child, but in case of children, if it is positive, yeah, the child has been infected with TB. Coming for lepramin test, it is usually for classifying the lesion. That is, classifying lesion means it is like which type. Okay, because if CMI is intact, it can come under what is a tuberculosis. If it is a negative, he can go for lepromatosis, leprosy, and you can assess the prognosis, whether the patient has been respond for the treatment or not, and also for usually assessing the resistance in leprosy, whether the patient had developed any resistance. So coming, see now, Lab diagnosis is over and test is over. Now coming for the treatment for bacillary. So here dapsone 100 milligram given daily. Here rifampicin 600 milligram once a month. It is given under the supervision. This both can be given for 6 months. Coming for multibacillary, again same. Okay, so dapsone 100 milligram daily for and rifampicin 600 milligram once a month. But here clofazimine is given 300 milligram once a month under supervision, and then he has to take 50 milligram daily. That is for 6 months and this is for 1 year. Okay. Okay. So coming for anti-tubercular drugs, first line, second line drugs. So first line, isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin. Second line, it is an ethionamide, cyclosporin, macrolides like clarithromycin, quinolones like ofloxacin and ciprofloxacin, aminoglycosides like kanamycin, amikacin and capreomycin. So here some of the important terms. If the patient has been labeled as multi-drug resistant tuberculosis, he is resistant to isoniazid, rifampicin. Okay, so with or without resistant to other line, but he is resistant to these both. Whereas extensive means he is resistant to fluoroquinolones and at least one injectable aminoglycosides like kanamycin, amikacin and capreomycin. Okay, so friends, this completes the Mycobacterium tuberculosis and the leprae. So just remember like this: what are the general characters? What are the I think I have differentiated. What are the general characters? What are the clinical features? What is the lab diagnosis? And what is the treatment? Enough. So next. This is again Actinomyces and Nocardia. These are the gram-positive bacilli, but they are the non-spore bearers. So here you won't remember, friends. These are the 5 points. Okay, 6 points. You won't remember this. So first, coming for acid fast. So you remember, just remember one. Either Actino or Nocardia. So Nocardia is okay. First Actinomyces is non-acid fast, and here Nocardia it is a partially acid fast. Whereas here it is an anaerobe, here it is an obligate aerobe. So Actinomyces usually causes an cervicofacial or the abdominal, and the most common here it is an cervicofacial actinomycosis. Whereas in Nocardia it causes a pulmonary nocardiasis presenting as lobar pneumonia, and extrapulmonary it usually presents as a brain abscess. So here coming for granules of actinomyces, what happens here is this granules are usually hard and it is not emulsifiable. Okay, but here it will be soft and it is an emulsifiable in the Nocardia. So here you will be seeing a typical sunray appearance. Okay, so because of the branching filamentous bacilli, it will be like a sunray appearance. So coming for culture of actinomyces, it is a spidery molar teeth colony in the solid medium, whereas here it will be creamy, wrinkled, pink and cotton wool ball. See, cotton wool ball appearance. Okay, so here the colonies are, just remember here spidery molar teeth, and here it is a cotton wool ball appearance. So coming for the treatment, here it is a penicillin, and Nocardia it is a cotrimoxazole. So next it is in gram-positive bacilli Corynebacterium diphtheriae. Okay, so it is in the club-shaped bacteria, and it will be having in granules that is containing polymetaphosphate or the volutin or baby's earnest granule. They are nothing but they are the energy deposits. So this usually requires an iron at the medium of 0.1 milligram per liter for their growth. So there is the powerful virulence factor, it is an exotoxin, and this exotoxin will be having an A and the B. It is similar to the Pseudomonas aeruginosa. Okay, so here this is special strain that is called as an PAN, Ponder, Albert and Neisser strain. So again here there will be a formation of the pseudomembrane, but the most common type of diphtheria, it is an facial diphtheria, and the most dangerous is laryngeal, because what happens is the pseudomembrane can extend and it causes an obstruction. So what's the lead complication here? It causes a post-diphtheritic paralysis, that too in the third and the fourth week, that is a late week. Here the palatine and ciliary reflexes will be affected, but the pupillary reflex will be intact. Okay, so coming for lab diagnosis, first it is an Albert strain and it is a Chinese letter pattern you can make out in the Albert strain, and the selective medium, it is in potassium tellurate agar. It usually shows in black colored colonies, and low flow serum slope you can make the growth in about 4 to 8 hours. So Schick's test is mainly for the immunogenicity. Okay, to assess the immune status of the patient, whereas Alex gel precipitation test is for the toxigenicity. Okay, so that is, it is by demonstrating the toxin and the antitoxin. So treatment, it is in penicillin. So the final, it is in Listeria monocytogenes. So again, it is in gram-positive bacilli, microaerophilic. So friends, again I am saying I am posting only as important points, but you must not leave a single point from this video. So first, it is a tumbling motility at 25 degrees Celsius, and at 37 degrees Celsius you can't make out any motility. So it will be growing in a cold enrichment medium. So in the utero, suppose if the patient in infant, it usually causes an granulomatosis infantis septicum, but if it is after the birth, up to third week, it causes an meningitis. So here the antigen test is positive, means if you are instilling the bacterial toxin into the rapid eye, it usually causes an conjunctivitis. So here the drug of choice, it is an ampicillin. If the patient is allergic to ampicillin, you can give the cotrimoxazole. Okay. So this completes the gram-positive bacilli non-spore bearing organism. So next video I will be covering the gram-negative bacilli. Okay. Thank you friends.